Almost everyone recognizes the experience of feeling depressed, and moodiness is almost universal. Because these experiences are so common, we need to critically examine the boundaries of mood disorders. How does depression differ from sadness? How does bipolar disorder differ from common moodiness? Is depression always a disorder in its own right, or can it be a symptom of another condition? It's estimated that if you could snap your fingers and make depression disappear, you would instantly eliminate 10% of all death and disability worldwide. In this video, I'm going to explore the current criteria for depressive disorders and bipolar disorders in the DSM-5 TR. Now, there's a lot to cover in these two chapters, but hopefully combining them will help you understand how they overlap and how they don't. So, types of depressive disorders. There's major depressive disorder, there's persistent depressive disorder, which now includes chronic major depressive disorder and dysthymia, disrupted mood dysregulation disorder. I talked about that one a bit already in the disruptive impulse control and conduct disorders video. Premenstrual dysphoric disorder, I'm not really going to talk about that one today, but as you see the pattern of the other depressive disorders, I feel like you'll be able to figure out and follow along as you read the DSM. There's substance or medication-induced depressive disorder and depressive disorder due to another medical condition. And then as far as types of bipolar, there's bipolar 1, bipolar 2. Those are both written with Roman numerals. Cyclothymic disorder, and again, with both, you'll be watching out for substance-induced, other specified, and unspecified disorders. There are a lot of ways that we can diagnose these disorders, but we need to make sure that what we're dealing with is actually a depressive or bipolar disorder. For example, depressive disorder due to another medical condition may be diagnosed when there's something like hypothyroid that is contributing to it. The common feature in all depressive disorders is a sad, empty, or irritable mood and clinically significant associated symptoms. For depression, what differs in the duration, the timing, or presumed etiology, and also the number of symptoms. For example, persistent depressive disorder has a much lower threshold for meeting diagnostic criteria than major depressive disorder. Bipolar adds an element of mania or hypomania to the mix, so first we need to understand depression before we dig into bipolar. So, for major depressive disorder or MDD, we can start with figuring out how to pull out the mood from emotion or depression from sadness. And one of the best ways I remembered this is thinking about how mood is clearly disproportionate to external stressors and time plays a role. Should depression be diagnosed if a stressor is present that would make almost anyone unhappy? The DSM-4 allowed for the exclusion of extended periods of symptomatic distress following bereavement, but did not apply the same rule to other losses. Life events such as divorce or job loss can produce symptoms that resemble grief. Depressive symptoms, whether caused by bereavement or other life stressors, are similar, and excluding grief helps to distinguish the normal from the pathological. Why not extend the exclusions to recognize that when people suffer losses, they can be expected to have transient depressive symptoms? This might make the diagnosis too open, too inflated, and a disorder might start entering into the realm of normality. But there are definitely fights on this topic, with researchers on each side, one arguing that symptoms he experienced after the death of his wife did meet criteria for a major depressive disorder. So there's thoughts of addressing these diagnoses or adding diagnoses like persistent complex bereavement disorder, but that's sort of a side topic. So back to what is major depression? So, for this diagnosis, a person has to have 5 symptoms that are causing clinically significant distress for 2 or more weeks. So, remember, blue for 2. And it's not due to a substance or medical condition. So, to note, up to half of all individuals in the general population will meet criteria at some point in their lives for some depressive disorder. The key feature of depression is a depressed mood. So, people in a state of depression generally feel terrible and will use words like sad, empty, hopeless, gloomy, miserable, wretched, lonesome to describe their emotional state. However, beyond just feeling depressed, there are additional features of depression that are often experienced as well. Depression involves disturbances in the following areas. First is sleep, with impaired sleep being experienced by more than 90% of people with depression. Depression causes not only difficulty falling asleep, but also early morning awakenings, disrupting both the amount and the quality of sleep that people are able to get. Next is reduced interest or enjoyment from activities like participating in hobbies or socializing with others. This hallmark symptom of depression is known formally as anhedonia. Anhedonia is what makes depression a non reactive state, meaning that somebody's mood will remain the same no matter what's going on around them. With somebody in a state of depression feeling no joy, even in situations that would normally inspire mirth, such as celebrating a birthday or getting a promotion at work. Guilt or hopelessness. People in a state of depression often find that their thoughts become focused on exclusively negative thoughts like guilt, worthlessness, or hopelessness. People will often ruminate on these thought patterns and chew them over repeatedly in their mind. Energy, with levels of energy and activity being severely depleted in depression, sometimes to the point where even getting out of bed in the morning is a major challenge. Concentration. So, people in a state of depression often find it difficult to concentrate, leading to impairments in work, school, and relationships. And then there's appetite, with the majority of people with depression finding that their appetite is decreased, which can result in noticeable weight loss or even malnutrition over time. People in a state of depression often describe food as unappetizing or flavorless, almost like eating cardboard. Then there's psychomotor retardation. While most symptoms of depression can only be subjectively reported, in some cases, depression involves signs that can be objectively observed by others. So, psychomotor retardation refers to general slowing of speech and physical movements and is generally considered to be a sign of severe depression. And then there's suicidal thoughts. For people in the depths of depression, suicide can sometimes seem like the only way out. Over half of all people die by suicide were in a depressive episode at the time of their death, making a link between depression and suicide quite clear. So you've got a lot of things to work with, but what I want you to think about is how some of these things relate. If you are experiencing a change in your weight, that often means that you're experiencing a change in your nutritional status, which can directly impact your mood. Sleep changes. Oh my gosh, you don't even grasp how important good quality sleep and stable circadian rhythms are to your overall health and happiness. When sleep gets disruptive, when your circadian rhythms get disrupted, you'll feel fatigued and you'll start having difficulty with concentration and indecisiveness. So there was a chunk of time over the summer where my dog was really sick, and I was getting up with her every hour, pretty much on the hour. So after a few weeks of that, I noticed a lot of mood issues in myself. The first night I was able to sleep through the night uninterrupted, I felt like a new person. Or if you've ever had a baby, you've experienced this sleep interruption where perhaps you felt like you were losing your mind. So sleep, it's a really big deal. And consider the populations of people that might not be getting great sleep or might not have it available to them. So think about active war zones, domestic violence situations, homelessness, right? So the mood lability that comes with lacking sleep can have huge impacts on mood. So when we're in a place of lacking sleep, it can have a huge impact on mood, which can also have a huge impact on people's decision-making skills and abilities to keep themselves safe. So sleep is a big deal, just as big as nutrition and hydration. So keep that in mind because these are all going to be connected. Now, persistent depressive disorder is somewhat different. Remember, major depressive disorder had to be for at least 2 weeks. Persistent depressive disorder has to be for at least 2 years for adults and 1 year for children or adolescents. So this goes by many names: persistent depressive disorder, persistent depression, dysthymia, and functioning depression are all names that you might hear. It's considered to be on the spectrum of depression, but differs from major depressive disorder in two key ways. First, it is chronic rather than episodic, with symptoms being present most of the time without a break for at least 2 years. Second, it's subsyndromal, and that individual does not quite meet full criteria for a major depressive disorder, but it still suffers from a depressed mood. Mood symptoms and dysthymia tend to avoid these symptoms of depression that are generally found in other more severe cases of depression, like that psychomotor retardation or thoughts of suicide. This suggests that dysthymia can be conceptualized as a milder but more chronic form of major depressive disorder. So, what you're looking at are chronic feelings of hopelessness, decreased energy, low self esteem, abnormal sleep, appetite changes, and impaired decision making that are all seen for a minimum of 2 years. Up to a quarter of all individuals with depression have both dysthymia and major depressive disorder in a clinical situation known as double depression. In these cases, the individual spends large portions of their life in a chronic subsyndromal state of dysthymia, punctuated with discrete episodes of more severe depression. So we've got major depressive disorder, we've got persistent depressive disorder, and then we have disrupted mood dysregulation disorder. And yes, I already talked about this one last week, but here we are again to make sure that you don't forget about it. Disruptive mood dysregulation disorder is only going to be diagnosed in a child between 6 and 18 years of age with an onset before age 10. So the onset of these symptoms has to be between 6 and 10. However, the diagnosis can be made up to age 18. So you might have to backtrack a little bit in your time machine. Now, on page 178, it says it only applies to children for up to 12 years. That's a typo. It used to say 12 years, but in the DSM-5, they changed it to 18 years old. So the hallmark of disruptive mood dysregulation disorder is persistent irritability. It's not just during the course of a depressive episode, it's just ongoing, persistent irritability that's disproportionate to recurrent temper outbursts, inconsistent with the developmental level, that happens at least 3 times every week in at least 2 different settings for at least 12 months with no remission greater than 3 months. So the child may be having these outbursts at home, at school, and for at least 12 months, at least 3 times a week. So that's a lot of outbursts that the child is demonstrating. And between outbursts, the mood is angry or irritable. Remember, children can be diagnosed with major depressive disorder, which is why I brought that to your attention. We want to look at the persistence of their irritability. Does it go on pretty much consistently, or is it only tied to a major depressive episode? While each of these will introduce a few unique wrinkles into the equation, they are all considered to be textbook depression as well. So everything we've talked about so far will apply. And then there's all these specifiers and subtypes. So the first subtype is melancholic depression. Historically, melancholic specifier was used to describe severe episodes of depression that seemed to come out of the blue as opposed to being brought on by life events that were completely non-reactive to external circumstances. So-called neurovegetative symptoms such as the psychomotor retardation that we've been talking about, severe loss of appetite, weight loss, fatigue, inattention, and disturbed sleep are particularly pronounced. Melancholic depression is best thought of as a very severe form of the disorder, and you may consider it to be more intense forms of treatment like electroconvulsive therapy, much more significant risk of suicidal ideation or suicide attempts. Another subtype is atypical depression. Atypical depression has some unique features compared to textbook depression. Most notably, mood remains reactive in atypical depression, and many people will experience a lifting of depressive symptoms during happy life events or worsening of symptoms during sad life events. People with atypical depression often display a long-standing pattern of interpersonal rejection sensitivity, even when not in an episode of depression. Now, that is an atypical feature that's worth noting. This would obviously point to some abandonment issues, potentially some attachment issues, but if you're seeing this persistent interpersonal rejection sensitivity, you're also going to want to make sure that you're ruling out cluster B personality disorders, specifically borderline personality. Other unique features are an increase in appetite rather than a decrease, sleeping too much rather than too little, and a sensation that one's limbs feels too heavy to lift. This is a phenomenon known as leaden paralysis, and it feels like you're either trying to move through mud or you're walking through a wind tunnel. In terms of treatment, a specific class of antidepressant drugs known as monoamine oxidase inhibitors, or MAOIs, is particularly effective for atypical depression. Postpartum depression develops in around 15% of women within a few weeks of delivering their child. It's unclear why the postnatal state increases the risk of depression, but many factors, including hormonal changes, sleep deprivation, childcare stress, are believed to play a role. Treatment is the same as for other cases of depression, with the exception of taking some additional considerations into account when choosing medications if the mother's breastfeeding. One thing to note is to rule out thyroid issues. It's important to recognize that thyroid dysfunction is relatively common in people after they give birth. So that would be one of those incidences of a medical condition creating the symptoms instead of the symptoms creating a depressive disorder. Then there's seasonal depression, also known as seasonal affective disorder. It's a subtype of depression where episodes have a clear link to the changing of seasons, with depression generally developing during winter months, most likely due to lower levels of sunlight. Treatment of seasonal depression involves bright light therapy for at least 30 minutes a day, although standard treatments for depression like meds and therapy are effective as well. Interestingly, the prevalence increases with higher latitudes. So, those that are in lower latitudes don't have as much seasonal affective disorder. And I think I remember it being somewhere around Nashville being the magical city. So, if you live north of Nashville, you're at a higher risk. Hey, Pittsburgh. And younger people are also at a higher risk for winter depressive episodes. Finally, psychotic depression is characterized by the presence of paranoia, delusions, and or hallucinations, in addition to all of the symptoms of depression that we talked about already. Treatment should involve a combination of both antidepressants and antipsychotics. So we're now finding as research has progressed that there's so much stuff that can contribute to depressive symptoms that has nothing to do with cognitions that I think a lot of times we miss. A lot of times we miss the lack of emotional intelligence, and a lot of times we miss the adverse childhood experiences that may be contributing to unresolved traumas. And what about systemic traumas? So think back to hydration, sleep, nutrition, exercise, the importance of all of that stuff too. So we need to get curious about each individual and explore what's going on with them. And remember, depression is a term that's a label that we assign to a bunch of symptoms. It's a word when somebody says, I'm depressed. It's a label that they're applying to a set of physiological and maybe even cognitive symptoms or presentation. But what causes those is often changes in neurotransmitters and hormones and the reactivity of the nervous system. So we really want to get down to the root of it and see what's going on with that person and what's triggering the cascade of changes, triggering that cocktail of hormones and neurochemicals that's maintaining their depressed mood. So as far as risk factors, we can talk about neuroticism. And that's a well-established risk factor for depression. Now, neuroticism means responding poorly to stress, interpreting ordinary situations as threatening, and experiencing minor frustrations as overwhelming. It tends to be temporally stable, so it's over time. It doesn't change. People tend to have difficulty responding. It's not just that they're overwhelmed right now, but across years, they have difficulty responding to stress, tend to interpret ordinary situations as threatening, and get overwhelmed really easily. But I want you to think about neuroticism and how it has a negative connotation to it. Couldn't somebody also develop these symptoms as a result of early adversity, as a result of ongoing trauma? So do we want to say neuroticism, or if we see these symptoms, do we also want to make sure that we screen for PTSD and borderline personality, maybe CPTSD, so the complex post-traumatic stress disorder? The impact of that trauma, ongoing trauma, and early childhood trauma may have an impact on how the person develops. If they have early childhood trauma, if they have early abandonment, they may not learn the skills to respond to stress. That means life feels very scary. So ordinary situations, for those of us who have developed coping skills perceive as ordinary, seem very threatening to them because they don't have the tools to deal with it. Therefore, they're persistently hypervigilant and exhausted, and minor frustrations, what most of us perceive as minor frustrations, may seem really overwhelming because they don't have the tools to deal with life on life's terms. So aside from neuroticism, multiple diverse adverse childhood experiences are strongly associated with the development of depression, and guess what? Probably also the development of neuroticism. But a lot of people believe that personality traits are inherent in a person, so they wouldn't be developed. But whatever your philosophy, it's important to recognize people who have adverse childhood experiences, especially multiple diverse ones, are at a greater risk of developing depression. A family history of depression. So we know there's a genetic component to it, and major depressive disorder is more likely in people with chronic medical conditions. We do need to recognize that if somebody has autoimmune disorders, fibromyalgia, some other chronic health disorder, especially if it's one that limits their ability to function and the way that they want to function, that it may contribute to a sense of hopelessness and helplessness and depression. Major depressive disorder has also been noted to complicate cardiovascular disease, obesity, and diabetes. So people with depression have more difficulty regulating their blood sugar levels. And in terms of sex and gender-related features, women tend to have more gastrointestinal symptoms, changes in appetite, and changes in sleep than men. And according to the DSM, men have more maladaptive coping, including substance misuse and risk-taking. And I would encourage you to also think about other addictive behaviors like sex addiction, porn addiction, gambling, or even, quote, workaholism. Many men, when they're depressed, they throw themselves into their work. So all they have to think about is work. They don't have to feel anything. And poor impulse control is associated with people who are biologically male than biologically female, according to the DSM. So there are three types of bipolar: bipolar 1, bipolar 2, and cyclothymia. So bipolar used to be called manic depression, and people with bipolar disorder go through periods where they may experience depression and they may experience mania or hypomania. So being really depressed or being really hyped. And there are periods in between that we call euthymia, which means they're really not super symptomatic of either one. Now, the research in clinical practice has indicated that even during those asymptomatic or euthymic periods, a lot of people with bipolar disorder still have a lot of mood lability. But it's important to recognize that people, even if they're not symptomatic of major depression or mania, it doesn't mean that they feel good. It doesn't mean that they feel great. And we need to educate the public and other people not to minimize the symptoms that happen in between the major episodes. So before we dig into bipolar more, let's talk about what it's not first. So we're going out of order a bit to consider differentials first, since you've already learned about most of these. So starting with borderline personality disorders and other personality disorders. So people with borderline personality disorder may also have mood lability. They may have this difficulty feeling happy because they're stressed out a lot. They're walking this tightrope, this borderline between feeling safe and feeling like they're in danger. So there's often a lot of anxiety, which contributes to hypervigilance and difficulty concentrating. They often have feelings of guilt and worthlessness because they don't feel like they're lovable. Sometimes they'll switch back and forth from feeling like they're all that and to feeling like they're completely worthless. One of the characteristics of borderline is switching back and forth between extremes of idealization and devaluation. So, really, really loving something or approving of it, and then really, really hating something. So, borderline also comes with a marker of self harm, suicidal thinking, or attempts. So, this can also just look a lot like depression. It can also look a lot like bipolar or even just mania when looking at likes, dislikes, mood changes. But the key here is differentiating between a mood disorder and a personality disorder. We want to recognize that people with borderline personality can have a lot of symptoms of bipolar disorder, and it's not uncommon to have somebody with both bipolar disorder and borderline personality disorder. Substances can also cause depressive symptoms when somebody's using depressants. Guess what? They're going to have more difficulty concentrating, may feel more tired, may have sleep changes, and there's a lot of symptoms in depression that you're going to see in people who are intoxicated with depressant type substances. Now, on the other hand, people who abuse stimulants, when they're crashing off the stimulants like cocaine or amphetamines, they'll often experience very intense depressive feelings and depressive episodes, but that's a direct result of the substance. Again, you have to look at what this person is experiencing. When are these symptoms occurring? And is it only linked to when they're using or when they're coming down off of use or withdrawing? So, have they had other episodes that are independent of the substance being in their body? So we can make an accurate diagnosis as to whether they're experiencing bipolar disorder or major depressive disorder until the substances are out of their body, or by a good clinical history. If we know that there have been substance-free periods where they've had these clinically significant symptoms, then that would point to potentially a mood disorder. And finally, psychotic disorders. So your schizophrenia, schizoaffective, may need to be addressed because they have depressive characteristics as part of them. People with major depression have psychotic episodes if they have significant depression. And we need to figure out if the psychotic episode is part of a psychotic disorder like schizophrenia, or is it a symptom of major depressive disorder? It's going to be really important to examine family history as well as what triggers it for the particular individual and when the psychotic episodes happen. The point being here that even with just psychiatric diagnoses, there's a lot of things that have depressive symptoms as part of what they are, and there are a lot of things that can co-occur with depression. So we may just have depression and borderline personality disorder and depression and PTSD and depression and substance use, or depression and all of those. They might be singular or they might be combined. So next we're going to talk about depression, because depression is half of bipolar, and it really is important to do a thorough assessment of the person to ensure that what you're dealing with is either unipolar depression or bipolar depression, because the treatment is different. Now, a lot of the treatment differences are between bipolar disorder and unipolar depression And a lot of those differences have to do with medications. So, typical antidepressants, your selective serotonin reuptake inhibitors, these can actually trigger a manic or hypomanic episode in somebody with bipolar disorder. So, we want to be careful what we're recommending. Likewise, a lot of your over the counter antidepressant substances like St. John's wort, saffron, 5-HTP, or SAMe can also trigger manic or hypomanic episodes in somebody who has bipolar depression. So, not only do we need to be careful with medications, but also supplements that our clients might be interested in taking. And bipolar depression is not the same neurochemically as unipolar depression. So, what works for unipolar depression psychopharmacologically is not going to be effective for somebody who has bipolar in general. So, bipolar has two poles. Depression is one pole, mania is the other. When we're talking about bipolar disorder, mania is when a person experiences an elevated mood and enhanced optimism, and they're on top of the world for at least 7 days or any duration if they have to be hospitalized. So, it could be only two. And if they're so elevated that for whatever reason they're hospitalized, if they have to be hospitalized, then that meets criteria for mania. Or instead of an elevated mood, they can have an irritable mood. And this can happen when somebody is manic and they don't get what they want. They can become very irritable, and this is what often results in the hospitalization because it's almost like a temper tantrum that can come with illegal actions. The person has to have this elevated mood or irritable mood for 7 days or hospitalization, and then we want to look at the following symptoms. So, distractibility, then there's insomnia. And insomnia in mania is not that they can't get to sleep and that they're desperately trying to get to sleep. Insomnia in mania is feeling like they don't need sleep and the next day having plenty of energy. So, somebody who's manic or hypomanic and in one of those episodes doesn't have a need for sleep as opposed to somebody who's depressed who may really want to sleep but can't get to sleep or stay asleep. I had a client a few years back that was an excellent example of insomnia in her manic episodes. She was really into crafts and fixing things up around her house. And during one of her manic episodes, she bought a bunch of vintage furniture and spray painted it all and then glued old newspapers across every single inch. She stayed up every night, all day, all night for 3 days straight, missed a therapy session with me, called me after the mania wore off, and described how she wasn't tired at all. She was just really motivated to flip this old furniture and knew that it was a great idea and she's going to make tons of money from it. And so then when she came to therapy the next time, she showed me the pictures that she took on her phone, and it wasn't pretty. And she looked at them and I looked at them. And I think it was the first time she'd really seen the pictures or seen the furniture since she started on them. And she was like, oh my gosh, I don't know what I was thinking. I swear it didn't look bad when I was doing it. But now that I'm thinking clearly, this is the thing. Physically, when we don't need sleep or when we don't get sleep, our brains aren't functioning at their best. Plus, the manic episode was full of goal directed behavior, which we're going to talk about in a second. So, grandiosity, a person who's in a manic episode may feel like they're 10 feet tall and bulletproof. They may think that they're all that and a bag of chips, and it might look a lot like a narcissistic personality disorder because they really think they're something and they aren't shy about telling you. So, it also might resemble what a stimulant high looks like. So, you have to pull those out a little bit. So there's a flight of ideas or racing thoughts. And a lot of people, when they're manic, will talk really fast and they won't give other people the opportunity to talk. And it can be a way that they monopolize conversations. And I know I'm a fast talker at baseline, but there's just so much content to tell you. And I'm really passionate. But you'll know this one when you see it. It's like you can't get a word in edgewise. And all of the words feel like they're pressured, like it's water in a fire hose. And the fire hose is turned on full blast. So all of those words are going to come out pressured and rapidly. And they can also engage in that goal-directed behavior. So goal-directed activities with poor judgment. And a lot of times people that are in a manic episode are going to go after things that are going to produce pleasure, like what looks like it's going to be the most fun right now. What can I do? I'm seeking an adrenaline rush. I'm seeking a dopamine rush. So goal-directed behavior is often towards pleasurable activities, but sometimes they can engage in specific goal-directed behavior, something that they wanted to do. So maybe they decide all of a sudden like, hey, I'm going to remodel the basement. And like, that's all they do. They just get immersed in it for hours and hours, maybe days and days, and you really can't stop them or help them to switch gears. Like my client with the vintage furniture, her husband could not get her to stop. And I think it's worth noting right now that people generally really enjoy the manic episodes. So it sort of sounds like a great strength to be hyper focused on something and not feel the need for sleep. You might notice a lot of artists who have bipolar disorder, and these symptoms, and I'm sort of using air quotes here, these symptoms can be great strengths and assets for their work. So when we talk about treatment in a bit, remember this might be part of the disorder that people don't want to lose. They're not seeing it as a symptom and will often refuse treatment because they don't want to miss out on the mania bursts. And thoughtlessness. This is an increase in pleasurable activities with the potential for painful consequences. The person in a manic episode is really seeking that adrenaline rush, is really seeking that pleasure rush, that dopamine, those endorphins. So they may engage in things like sex, spending, substance use, and other adrenaline producing activities like reckless driving, skydiving, even shoplifting. Anything that's going to provide them a rush is potentially appealing to somebody who is in a manic episode. Now, mania can be misdiagnosed for a variety of things. Generalized anxiety disorder has a lot of similar symptoms. When people have generalized anxiety, they tend to be kind of hyped up. You might see that they're more distractible. So when we're anxious, we tend to be hypervigilant and we tend to be more distractible. Insomnia in generalized anxiety is more of an inability to sleep because they're so revved up, because they're so stressed, not because they don't need it, but because they just can't shut their mind down and they're really, really stressed. So they might want to go to sleep versus somebody in mania who doesn't want to go to sleep. And the person with generalized anxiety might have a flight of ideas or racing thoughts too. So generalized anxiety means that they're anxious about a variety of things. It's not just one thing in particular. So their thoughts may bounce from this thing to they're stressed about to this other thing that they're stressed about to this thing over here and this other thing. So that's not uncommon when they start thinking about those things. It amps up their anxiety and they'll often start thinking catastrophically, which can increase their fight or flight reaction. So they might start thinking and talking even faster because they're getting into that catastrophic, oh my gosh, the world is going to end place. So they may engage in more goal-directed activities because they're trying to stop the anxiety. So if I do these things, maybe, I'll focus all of these healthy behaviors. And if I become very rigid in what I do, then I'll be able to avoid abandonment and I'll be able to avoid getting sick and avoid all these other things that might make them anxious. But their goal-directed behaviors are specifically oriented to reducing the anxiety. So whatever they're doing is trying to reduce the anxiety. It's not goal-directed for pleasure. It's goal-directed to make the pain stop. And that's very different than mania. So when you're diagnosing, you want to have that conversation with that individual about why are we doing what we're doing? Is it to feel good or is it to stop the pain? People with PTSD or CPTSD often have some depressive symptoms because of their hypervigilance, and they may continue to have distractibility, just like we talked about with the anxiety. They may also continue to have an inability to get quality sleep or insomnia, and it's not that they don't need it, they just can't get it. They may have a flight of ideas or racing thoughts, many of the same symptoms that you see with generalized anxiety, and for the same reasons. The flight of ideas or racing thoughts are all about how can I stay safe in this environment where I don't feel safe anymore. People with ADHD or impulse control disorders may also have bipolar or get misdiagnosed with bipolar because they have that distractibility. Many people with ADHD and oppositional defiant disorder, we're going to see that mood lability. We're going to see some activities that are pleasure focused. And people with ADHD, interestingly enough, we tend to think of them as not being able to stay focused, but sometimes if it's something that they're really interested in, they can get hyper focused. So you might see that hyper focus in people with ADHD. Okay. So you know about depression and you know about mania. Put those two things in a bowl together, swirl them around, and you've got bipolar, right? Wrong. There are some extra stipulations in the diagnosis of bipolar, and it's not super simple because everything exists on a spectrum. So we've seen a diagnostic epidemic largely because of the preference for identifying conditions that can be managed with drugs or medication. It's opened the door to a major expansion of the bipolar diagnosis so that all phenomena marked by mood instability can be seen as reflecting milder forms of bipolarity on a spectrum. Bipolarity came to be defined in ways that expand into the boundaries of other mental disorders, and some have claimed that it's present in a large percentage of individuals who see psychiatrists. This tendency to see mood disorders, personality disorders, and impulsive disorders as bipolar has spread rapidly. Some researchers state that 40% of all psychiatric individuals are bipolar. So, when taking a deeper look at a lot of people diagnosed with bipolar, their symptoms can often be better described in other diagnoses. So, we want to be mindful when we're diagnosing this and everything that we're not just seeing what we want to see or seeing what feels easier to treat. So, we need to be aware of a few vocabulary terms in order to help us diagnose. And I know it's like learning a whole new language. So, starting with hypomania. Hypomania is when somebody has three symptoms of mania for a period of 4 days, and it's not necessarily the 7 days, and they're maybe not clinically significant. They never result in hospitalization, and the person can function. So, there's a definite alteration in their presentation, but they're able to function during a hypomanic episode versus during a manic episode, not so much. Rapid cycling is something else that we hear a lot about. And when somebody rapidly cycles, it doesn't mean every 30 minutes, which is a misconception that a lot of people have. And probably most of those TikTok videos that are self diagnosing think that all bipolar is rapid cycling. And the rapid cycling is much more rapid than it actually is. Rapid cycling means 4 or more mood episodes within a 12-month period. And this can be for depressive episodes, it can be for manic episodes, it can be any combination of them. It doesn't have to be 4 mood episodes in 40 minutes. That's the difference between mood and emotion. And if you're witnessing something that seems a bit more ultra rapid, you might want to point yourself towards the personality disorder chapter more than the mood disorder chapter. And also consider substance use and eating disorders too. Another misconception with bipolar is that people alternate and they'll go from depression to mania to depression to mania. And it's not like that. It's very random which mood gets triggered. It doesn't have to follow a pattern. And working with somebody with bipolar disorder, many times you can identify particular triggers for each pole, but it's definitely not an expected depression mania alteration. A mixed episode may include elements of the other pole, and mood lability is really common in people with bipolar. Even during a significant episode, they may have symptoms of the other. So, people having a depressive episode and have a burst of manic energy or burst of mania during that period are still in a major depressive episode, and they're in a mixed episode at that point. Generally, one pole will dominate, but you'll have some breakthrough symptoms of the other. So, some people with bipolar disorder may only have an episode once every few years. And I know a lot of people that I work with are like, oh my gosh, wouldn't that be wonderful? Unfortunately, the people who only have an episode once every few years aren't often diagnosed at all. And that's because it's one of the places that we would miss in a diagnosis because generally people chalk it up to a one and done, or they don't look for patterns in what's going on, or provider hasn't been working with them long enough to see that pattern, or a client isn't a good historian of their experiences, or you throw substance use in the mix and people start blaming the substances instead of seeing the mood underneath it. It's important to ask people about historically, not just the past year or in the past 5 years, but over the course of their life. Have they had other depressive or manic episodes? And I have a client who's been seeing me for opioid and alcohol use disorders for a while now, and he's got this co-occurring process addiction or cross addiction related to sex. He has hypomanic episodes once a year, about every 8 to 12 months, and we've tracked this pattern together for a while because the first thing that he starts doing is picking fights with his long-term girlfriend, threatening to leave, downloading dating apps to his phone, and has this very grandiose sense of himself and goal-directed behaviors towards seeking out casual sex. Before he was sober, instead of sex, this was linked to a relapse pattern for alcohol and for pills. So in about 2 weeks after it starts, it usually passes. But if he starts to act out on his sexual compulsions, it will result into relapses into his substances of choice too. So for him, he's denied suicidality multiple times, but when he's entering hypomania or even just coming out of the depressive fog, there's almost this little switch that happens, and it's really easy for me to catch because we've been tracking it and working together for so long. But I know that when he starts talking about women and sex and picking fights, we go to DEFCON 3, threat level midnight, lockdown, crisis intervention, relapse prevention mode. And you would do the same for someone if they've expressed suicidality in the past. You just jump straight into safety planning, even though they may say, no way, I feel great. This is so much better than the depression poll, because we know that what comes next is not going to be conducive to their goals, to their values, to their morals, to the way that they want to live their lives. So we talked about there's 3 different types of bipolar disorder, 1, 2, and cyclothymia. So for 1, the person has to have at least one full-on manic episode during their lifetime, not during the year, during the lifetime, and a depressive episode is not required. So if somebody presents and the only symptom that they've had is mania, then they qualify for bipolar 1. If they present to you and they've had at least one major depressive episode and one hypomanic episode, then they qualify for bipolar 2. So think of addition here as a way to remember. So one depression plus one hypomania equals 2. Only one mania equals 1. Now, major depressive is pretty clear. Hypomanic, remember, I said it doesn't have to cause significant impairment in functioning, and we do want to screen for hypomanic. So major depressive plus hypomanic is bipolar 2. And then remember, euthymia is that feeling that they get between episodes. So sometimes euthymia can look a little hypomanic-y because that person is so relieved to finally have their energy back. They're like, oh, I'm back, let's go. But we do want to carefully differentially diagnose that and not diagnose somebody with bipolar 2 who actually has unipolar depression and it's really just good euthymia. And then there's cyclothymic disorder or cyclothymia, when the person has hypomania and a persistent depressive disorder that lasts for at least 2 years, right? So remember, this is the more chronic but less intense. So we talked about persistent depressive disorder before, but maybe now since we know what hypomania is, you can start thinking about it as it's sort of like a hypodepression, where the person's symptoms are not clinically oppressive, but they're present. The person has the difficulty feeling happy. It goes on to a low-grade depression that lasts for at least 2 years. So during that 2-year period, they have to have at least one episode of hypomania. So long-term hypodepression and a bit of hypomania sprinkled in is cyclothymia. So unfortunately, depression carries a significant mortality rate. Mood disorders are found in the majority of people who die by suicide, and up to 5% of people with depression will eventually take their own lives. Depression also worsens outcomes for a variety of medical illnesses, including cancer, heart disease, and stroke, leading to overall decreases in life expectancy up to 10 years, even after removing suicide from the equation. Now, in terms of risk for suicide, the prevalence of suicide, according to the Journal of American Medical Association, between 2014 and 2019, the suicide rate increased by 30% for Black individuals and 16% for Asian or Pacific Islander individuals. From 2019 to 2020, though, now think about what was going on during those times. We're looking at pandemic-y type of stuff. The suicide rate declined overall by 3%. But it's interesting to note that during that period at the beginning of the pandemic and the height of the pandemic, suicide rates allegedly were declining overall. What's your hypothesis? What's up with that? Then the transgender population is really important to note. 42.9% of people who are transgender indicate that they had depression and suicidal ideation, and 29.1% of people who identify as transgender had at least one or more suicide attempts. So that's really important to know. And I pulled this graphic from the CDC, and this is from 2018 when they reported suicidality was up 30%. So that's since 1999. And I know there's a lot of statistics here and a lot of numbers, and I think this map helps out a little bit with understanding. And I think it's interesting to see specifically where it's going up or where it's going down. So what's up with Nevada? Y'all want to move. Remember, I talked about that latitude connection with Nashville being the magical latitude to look out for with seasonal depression. So notice Tennessee as a dividing line across the states, stronger increase above. So postpartum is interesting to look at too. Women reported lower depression scores and higher suicidal ideation incidence. So their depression scores were around 6.6, but their suicidal ideation was about 12% in the early postpartum period. That's important to recognize the early postpartum period. And for some people, the peripartum of the month before delivery, there's a significant increase in the likelihood of major depression as well as suicidal ideation. Now, another thing that they don't tell you in the book, suicide risk in fathers in the postpartum period. And I think it's so important because the health of the caregiving system is so vital to the health of the infant. We can't just pluck out the birth parent and focus on them. We need to focus on all of the caregivers. So suicide risk in fathers in the postpartum period was 4.8%. Fathers with postpartum depression, or 21%, are more likely to present suicide risks than those with mixed episodes. So they had depression as well as symptoms of hypomania that didn't quite meet the criteria for a hypomanic episode. Those were 46 times more likely to present with suicide risk than those who did not suffer from any mood disorder. So, suicidal ideation in fathers with postpartum depression, either simple postpartum depression or postpartum depression with mixed features, is significant, and we need to be aware of it because that's what's going to impact the health of the caregiving unit. Seasonal affective disorder and seasonal patterns in major depressive disorder. So, interestingly, suicide rates increase in the spring and summer and actually decrease in December, with the lowest through Christmas. They peak on New Year's Day and go back to the yearly average thereafter. Now, they hypothesize that the perception of one's own depression and despair is enhanced in the spring by the perceived difference between the outer world, that sunny, bright, nice little world full of flowers and sunshine, and outside people are eating ice cream and having fun, and then the inner world, which is dark. So, whereas during the winter, even though there's less daylight hours and circadian rhythms get all out of whack and disruptive, the outside feels dark and dreary, and the inside also feels dark and dreary. So there's less dissonance there. So that's just one hypothesis. But I think it's important for us to note a lot of times we assume that the holidays is when suicide peaks, and that's actually not true. Suicide rates actually increase in the spring and summer. And I know I talked about dehydration as a factor on medication efficacy, and this may also play a role. Maybe the SSRIs, tricyclics, aren't working as well if the person's hydration is out of whack, and we generally see dehydration in the spring and summer. Premenstrual dysphoric disorder. So this is a unique diagnosis in the depressive disorders, but I thought it was important to mention here. When we're talking about suicide, people with premenstrual dysphoric disorder are at a greater risk for suicidal ideation and suicide attempts. However, suicide attempts are not related to the menstrual cycle. So assuming that somebody is going to become more suicidal, more emotionally dysregulated and impulsive when their hormones or when there's a switch happening with their body, it's not quite accurate. It doesn't seem to follow a pattern as you might suspect. Suicide among individuals diagnosed with bipolar disorder is approximately 10 to 30 times higher than that of the general population. And that's really big, which underscores the fact that it's even more important that if you think that you're diagnosing somebody who's presenting with PTSD or who's presenting with borderline personality disorder or substance use disorder, that whatever their primary diagnosis, don't miss a bipolar diagnosis. So one of the most dangerous times for somebody with bipolar disorder is actually when they're coming out of a depressive episode and they're starting to get their energy back, or even when entering into a manic or hypomanic episode. When they have that energy, goal-directed behavior, thoughtlessness, etc., it doesn't mean that they're not in danger the rest of the time, but it is important to recognize that if you're treating somebody, maybe you're treating somebody for PTSD and you miss their bipolar disorder. When they start seeing you for PTSD, they were probably really depressed, and now they're starting to come out of that fog, and you're like, score, we're making progress here. Be careful, because that could actually really be one of the most dangerous times for them regarding suicide. So treatment for depression consists of psychotherapy, medications, or a combination of the two. And while therapy and medications are both effective, the combination is better than either one alone. With treatment, the average length of a depressive episode can be reduced from 6 months to less than 3 months. In terms of therapy, several types of psychotherapy appear to be helpful. With the most well-studied is cognitive behavioral therapy, or CBT, which focuses on the connections between thoughts, feelings, behaviors, and teaches specific skills for breaking out of the cycle of depression. You'll also want to look at dialectical behavior therapy, acceptance and commitment therapy, mindful-based cognitive therapy, and EMDR, and there's a ton of others that are really helpful too. Medications used to treat depression are known as antidepressants, and most of these drugs work by increasing levels of neurotransmitters like serotonin, dopamine, and norepinephrine that are active and available in the brain. Antidepressants are helpful for treating depression, although it's important to point out that medications can take some time to work with a full effect, not even being seen for maybe up to 2 months after starting the drug while treatment works. So for many people, it's not 100% effective. Instead, treatment response in depression appear to follow a rule of thirds, with about 1/3 of individuals receiving treatment experiencing complete recovery from their symptoms, and 1/3 noticing some improvement but not complete, and 1/3 not getting better at all with the first treatment tried. Individuals who have not received any benefit, even after multiple trials of therapy and medications, are considered to have treatment resistant depression. In these cases, other treatments such as electroconvulsive therapy or ECT may be considered. And while ECT is an invasive and complicated procedure, it's highly effective with the largest effects seen of any single treatment for depression. So, breaking down these antidepressants a little bit more, there's selective serotonin reuptake inhibitors or SSRIs, and they were launched in the mid to late 1980s. This generation of antidepressants is now one of the most common classes used for depression. Some name brand examples are Celexa, Lexapro, Paxil, Prozac, Zoloft, and two newer meds that I'm seeing commercials for them all the time are classified as serotonin modulators and stimulators, or SMSs, meaning that they have some properties of SSRIs but also affect other brain receptors. There are things like Vibrid and Trintellix. And then there's serotonin and norepinephrine reuptake inhibitors. So that's a newer type of an antidepressant, and that class includes Effexor, Pristiq, Cymbalta, which interestingly helps with nerve pain. And then there's tricyclic antidepressants, and these were some of the first medications used to treat depression but aren't so common anymore. And really, I've only ever seen them used if the newer types weren't working. So that might be something like Elavil. And then there's the MAOIs, the monoamine oxidase inhibitors, and these were among the earliest treatments for depression. So MAOIs block an enzyme called monoamine oxidase that then causes an increase in brain chemicals related to mood, such as serotonin, norepinephrine, and dopamine. So examples are Nardil, Parnate, Marplan, and there's also a skin patch that is fairly new and on the market too. So although they work pretty well, they're not prescribed very often because of the risk of serious interactions with some other medications and certain foods. So foods that can negatively react with MAOIs include aged cheeses, aged meats. Sometimes you might hear something about grapefruits too. Other medications worth noting is Wellbutrin. It's a unique antidepressant that's thought to affect the brain chemicals norepinephrine and dopamine, and it's less likely to cause the sexual side effects of other antidepressants. And then there's a new one on the market, it's fairly new, Spravato, or ketamine, is a unique medicine originally developed as an anesthetic and thought to treat depression through its effects on the neurotransmitter system, or specifically glutamate. And it's administered through a nasal spray and also IV infusions. It's used for those who have not responded to treatment in any other antidepressant. And its most common side effects include sedation, dissociation, problems with thinking, and high blood pressure. This one is also fairly abusable, so we have to be careful. And there's a whole host of others out there that aren't FDA approved yet, or are being used off-label or being researched, like microdosing mushrooms, LSD, MDMA. All those fun drugs are recently coming to the forefront with some possible use to treat depression. So you might want to keep your eyes on that. And then as far as bipolar treatment, in terms of treatment, I mentioned that medication is going to be a part of most people's treatment regimen because bipolar disorder does have a significant biochemical component to it. Medications that would be considered here in the antipsychotic class, so that's risperidol, Zyprexa, Seroquel, Geodon, and Abilify. They would all help stabilize moods and bring those big swings up and big swings down to more even keel. SSRIs or antidepressants can be prescribed, sometimes in combination with those other classes, but we have to be mindful here because there's research that notes that SSRIs can trigger manic episodes or add suicidal behaviors where they weren't previously present. Anti-manic medications will help to really just target the mania, so maybe we're looking at those for bipolar 1, and those would be lithium, Depakote, Lamictal, along with some of those antipsychotics too. Lithium tends to be a heavy hitter, but is fairly commonly prescribed, and it's a little bit of a dance to get the dosage levels right for each individual and comes with significant side effects. All of those take time to build up in the system, so it's not a magic bullet where once you take it, the symptoms go away. It takes consistent daily dosing, which can be difficult to maintain no matter what pole a person might be in. And the other med compliance issue that I run into for a lot of folks who are taking meds is, it's not just when we're talking about bipolar, but it's when this med has built up in the system and the person starts to feel better, so much better that they start to question if they even have the diagnosis at all and if they even need the meds at all. So they just stop taking them and symptoms will return, and this can happen quite often. So additionally, they found research-based approaches through nutrition and A1C or blood sugar management management, reducing oxidative stress, maintaining blood sugar levels can reduce the number of episodes. Circadian rhythm regulation with what they call chronobiological treatments. So some of those are behavioral and some of them are medicinal, like melatonin has been used for some, and some stronger aids to help people to get to sleep have been used in certain circumstances in order to help people reset their circadian rhythms after an episode, and sometimes even will help maintain their circadian rhythms as much as possible during an episode. Stress management, mindfulness, and vulnerability awareness and prevention are also really important because we know that stress increases the likelihood of clinical symptom, increased functional self efficacy. As people start to feel more in control and they start recognizing, hey, there are things that I can do to help control my moods a little bit and help deal with this a little bit more, and I can improve my own quality of life, a lot of times hope and optimism start to go up. It just makes sense where you start to feel more in control of your own body, you feel more optimistic, you feel more empowered, you feel safer, you might feel less depressed. And finally, develop plans to address specific symptoms that that person has. Not everybody has all of the symptoms. So we want to say which symptoms do you have, which ones are most problematic for you, and let's talk about what works and what doesn't work to address those symptoms. So, depression marked by persistent feelings of sadness, hopelessness can lead to significant mortality rates and worsen outcomes for various medical conditions. When people get depressed, when people get stressed, it alters their vagus nerve, sends out signals, it alters their microbiome. And when their microbiome gets out of whack, it can actually contribute to depression. So, it's a bidirectional problem. And depression is strongly associated with developing systemic inflammation and nutritional deficiencies. And depressive disorders are also associated with a host of comorbid disorders. We need to make sure that we're addressing the whole person, we're addressing all of the trauma and all of the personality issues, all of the mood issues, but that we're also addressing the physiological issues that may be complicating or contributing to their presentation. Bipolar disorder, characterized by extreme mood swings between depressive and manic episodes, poses unique challenges in diagnosis and treatment. We discussed the spectrum of bipolarity, encompassing hypomania, rapid cycling, and mixed episodes, and the highlight of importance of recognizing subtle symptoms for accurate diagnosis. Various psychotherapy modalities, including CBT and DBT, offer effective approaches for managing depression and bipolar disorder. Additionally, we explored the role of pharmacology and lifestyle interventions in symptom management and relapse prevention. By understanding the nuances of depression and bipolar disorder and treatment, counselors can provide comprehensive care and support to individuals experiencing these challenging mental health conditions.